We'll start with the first presentation from Medicine 3, It's Everywhere, by Dr. Sam Arul Manoj. I request everybody to stick to time, like maximum 12 minutes, so that we can finish on time.
Good morning, everyone. Presenting on behalf of Medicine 3. Presenting Mrs. B, a 39-year-old female para 4 life 4, grand multiparous woman whose last childbirth was 16 years ago, who presented with chief complaints of passing clots of blood per vaginum for the past 2 days and difficulty in breathing for 1 day. So her timeline goes like this. She was apparently well 3 months before. Then she developed heavy menstrual bleeding, for which she had taken hormonal contraceptive pill. But her bleeding did not subside. On December 13th, 2022, she came to our emergency department with complaints of bleeding PV and left lower limb swelling and pain for 3 days. So considering a possibility of deep venous thrombosis, left lower limb DVT screening was done in the which was positive. She had a left subacute chronic thrombosis in the left superficial femoral, common femoral, and left external iliac veins. So she was given therapeutic anticoagulation with injection low molecular weight heparin, and she was also prescribed injection leuprolide and norethistone for the heavy menstrual bleeding part. But despite that, her heavy menstrual bleed did not settle. So she was basically planned for a surgical procedure, hysterectomy. But since she was started on anticoagulation, vascular surgery consult was sought for, and she was IVC filter was inserted for her on December 19th of 2022, and she was discharged the next day on tablet dabigatran and tablet primalut. And she came to follow up on 10 days after that, and she was advised to stop dabigatran. But on Jan 5th, patient by herself took dabigatran, and she again had a heavy menstrual bleed following that, and she again presented to ED on 9th, which is the present admission. So she was basically admitted under gynae department with passing clots of blood and dyspnea, which was grade 2 according to New York Heart Association. On Jan 12th, that is 3 days after admission, we have been called for emergency consult, stating the patient is having sudden onset worsening of breathlessness. So on Jan 12th, around 9:30 a.m. in the morning, she developed sudden onset dyspnea, which was grade 4 according to NIGA. Otherwise, there is no history of chest pain, no palpitation, no fever, cough with expectoration, no abdominal pain or distension, no oliguria. So she was diagnosed with diabetes 1 month before, for which she was started on tablet metformin. Menstrual history wise, she attained menarche at 14 years. She has a regular menstrual period. There was no history of intermenstrual spotting or a postcoital bleed. She is a para 4 life 4. All 4 childbirths were by normal vaginal delivery. Last childbirth was 16 years ago. So on examining the patient, she was conscious oriented, afebrile, she was tachypnic, she was pale, bilateral pitting pedal edema, right side, right more than the left. She also had a right calf muscle tenderness. JVP was not elevated. Vitally, she was tachycardic with 120 beats per minute and tachypnic with 28 breaths per minute. BP was 128, saturating 94% in room air. Her systemic examination of cardiovascular, respiratory, perabdomen, central nervous system were normal. So summarizing, she's a 39-year-old grand multiparous female with history of heavy menstrual bleeding over the past 3 months. Had a left lower limb DVT for which she had underwent IVC filter insertion. Had now presented with grade 4 dyspnea. And clinically, the patient is pale, tachycardic, tachypnic, along with the right cough tenderness. So I would like to ask you for the differentials.
The number you have to give, no? The code they have to enter. It's not
Yes.
there.
Code is 3890168. 3890168.
Yes, so there are two differentials.
Okay. Thank you for your response. So the differentials considered were acute pulmonary thromboembolism, acute myocardial ischemia, acute decompensated heart failure, cardiac tamponade, and pneumothorax down the line. So her investigations revealed hemoglobin of 6.6, which is a microcytic hypochromic blood picture, which increased RDW. Otherwise, her renal function test, liver function test, electrolytes were all within the normal range. So this is the ECG done at that time. Sorry, because it was not that clear. Actually, this ECG had a S wave in lead 1 and a T inversion in lead 3. And her well score for pulmonary embolism was 9 points, which denotes a high risk for a pulmonary thromboembolism. Echo showed a normal LV function, no RWMA, EF was 59. So we asked for an emergency CT pulmonary angiogram, which showed an acute pulmonary embolism involving the right and left branches of main pulmonary artery. She also had features of right heart strain. Since she also complained of right calf muscle and tenderness, we also did a DVT screening of the right lower limb. And it also showed a acute deep venous thrombosis in the right lower limb, extending up to the bifurcation of right common iliac vein. So we are struck at this point because the patient had underwent IVC filter insertion just a couple of weeks ago. So we just wanted to ascertain whether the position of the filter. So we did a non-contrast CT abdomen to look for the position of the filter. So it showed the IVC filter in situ, and the filter around the filter also there was a thrombus. So basically for this recurrent thrombosis, we have considered the following differentials: antithrombin deficiency, protein CAS, prothrombin mutation. So the entire, the complete coagulation profile we are not able to do since the patient had an active thrombus at that point of time. There was no history of trauma or immobilization. Oral contraceptive history was there. APLA workup we sent was negative, and the PNH and malignancy was considered down the line. So basically, I would like to, the final diagnosis made was a recurrent thrombotic state with left lower limb DVT status post IVC filter insertion, and now with acute pulmonary thromboembolism and acute right lower limb DVT. So I would like to highlight on the role of inferior vena cava filters in the management of venous thromboembolism and the risk of pulmonary thromboembolism even after IVC filter insertion. So basically, IVC filters came into play in 1973. Basically, so how they will place is, so this is the external iliac vein, which is the continuation of the femoral vein. And here the internal iliac vein joins, and here we have the common iliac vein. So common iliac vein on both sides join the IVC over here. So these two are the renal veins. So basically IVC filters are kept in the infrarenal part of the IVC over this area. So this is how the IVC filter is placed through a femoral venipuncture. So the use of inferior vena cava filters, based on the evidence, there were three conditions. One is a proven venous thromboembolism with contraindications for anticoagulation, and those with complications of anticoagulation, and those with failure of anticoagulation. Contraindication wise, for filter placement, if there's a chronically thrombosed IVC, then obviously we cannot do it. So those three are the main evidence-based indications. So this is the comparison of the major guidelines of 4 major societies. So American Heart Association and Society of International Radiology, they all recommend IVC filter placement for acute proximal deep venous thrombosis or a pulmonary embolism, and those with contraindication for anticoagulation, as I have mentioned in the previous slide. So IVC filter has its own complications. So some of which are IVC thrombotic occlusion. Even a thrombus can go and occlude in the filter itself, and IVC can penetrate through the walls of the inferior vena cava. Filter itself can get embolized, and filter movement is like a movement that is more than 2 centimeters from the position where it is actually placed, and parts of the filter can get fractured and dislodged, and access site thrombosis and all. So this is one case report of a pulmonary embolism which happened after IVC filter insertion, which is reported in US, a 64-year-old male who underwent revision posterior spine fusion 2 years before he was placed.
You have another minute.
Sorry,
you have 1 more minute.
Okay. He also sustained sudden cardiac arrest, and the imaging showed a massive pulmonary thromboembolism. This is a clinical trial published in the NEJM of vena cava filters in the prevention of pulmonary embolism. So outcome assessed at 12 days showed overall, I mean, people were assigned in 2 groups, one with IVC filter, one without a filter. In the people with IVC filter, the incidence of pulmonary embolism was 1.1%, whereas it was higher, 4.8% in the other group. When these people were followed up for 2 years, the incidence of pulmonary embolism was 3.4% in people with filter, and without filter it was high, 6.3. But the incidence of DVT was little higher on the filter group. It was 20.8%. This is an 8-year follow-up of patients, a pre-pick randomized study in which 400 patients were randomized into 2 groups. Again, here if we see in patients, those with filter, the symptomatic pulmonary embolism was little lower, 6.2%, than compared to the other group without filter. But here again, the DVT incidence is higher in the filter group, that is 35.7% compared to the other group, 27.5. Even in this graph, we could easily make out this is the incidence of pulmonary embolism, which is lower with the IVC filter group, whereas DVT incidence is higher with the filter group, whereas survival probability is almost the same in both the groups. So this was the conclusion made. At 8 years, vena cava filters reduced the risk of pulmonary embolism, but it increased the risk of DVT and had no effect on survival. So the learning point which I would make is which I would like to mention, the indications of IVC filter. That is those with contraindications of anticoagulation, those with complications of anticoagulation, those with failure of anticoagulation. And we must also consider the possibility of a pulmonary embolism or a DVT even after IVC filter insertion. Thank you.
Thank you, Dr. Sam. Any questions from the audience? How is your patient?
Patient is, we have started on therapeutic anticoagulation with low molecular heparin. So then we bridged with warfarin and we have discharged her. Currently, she's on warfarin. She is doing well. She's under our OPD follow-up.
So that brings me to my first question. Why did you stop the anticoagulation in December? You know that even despite putting an IVC filter, it's an nidus actually for formation of thrombus in people who have prothrombotic state. So why was a decision made?
vascular department.
So you should remember not to stop anticoagulation after putting in IVC filters also. Because your patient, despite putting in an IVC filter, she's developing spontaneous thrombus in the pulmonary circulation. She's not having a clot which is migrating from the lower limb vessels to the pulmonary vessels. So she's got a very severe prothrombotic state. The other issue, she had bleeding and thrombosis. So did you look for something like a DIC? Did she have a malignancy related DIC? Or you thought both were separate diseases?
Malignancy thing we haven't extensively evaluated.
Okay.
Thank you.
We go on to the next case from medicine.